Welcome to the Microdosing for Healing podcast. I'm your host, Casey Garrett, and together we'll be discovering and learning from inspiring voices of healers, medicine keepers, and visionaries. Every episode, we'll explore the world of health, vibrant wellness, and natural medicine for a new era of human society. Welcome to today's episode. Hello, everyone. Welcome to the podcast. Thank you for being here. So I'm really excited to introduce you to these three bright lights today. We're going to be delving into the topic of ketamine. So over the last couple of years on our Microdosing for Healing applications, I always ask people, what is their experience? Have they worked with any medicines in the past? And ketamine, I see increasingly showing up. Lots of people have questions. Lots of people are drawn to it, want to learn more. And we're also in a moment where there is so much information on the internet, for better or for worse. So I'm really excited to have three experts in this space working from in very distinct areas of the country, different populations, have very different approaches to give you a really well-rounded, rich episode, especially around ketamine. So please welcome Dr. Michelle Weiner, Dr. Erica Berger, and Amanda DiMartini. I'm going to read their bios to you now to get started, and then we'll delve into our conversation. So Dr. Michelle Weiner is based in the Miami area and is a double board certified in interventional pain medicine, physical medicine, and rehabilitation. She is the founder of NeuroPain Health, integrative pain management, and mental health centers in South Florida focused on neuroplasticity and healing. She is a clinical assistant professor at Nova Southeastern University, and her research at the University of Miami compared psychedelic versus psycholytic doses of ketamine to treat chronic pain and depression. Her cannabis research focuses on using cannabis as a substitute for opioids in chronic pain patients and cannabis's effect on seniors with chronic pain. Dr. Weiner's unique approach to personalized integrative pain management allows her to treat the root cause of one's pain and suffering, both physical and emotional, providing comprehensive and durable relief. She uses a biopsychosocial model, including lifestyle and plant medicine, to empower her patients to cultivate health and optimize quality of life. Dr. Weiner was trained in ketamine-assisted psychotherapy by the Ketamine Training Center and incorporates a multidisciplinary, patient-centered approach. Dr. Erica Berger is based in Iowa and an integrative psychiatrist and the founder of Driftless Integrative Psychiatry. She specializes in ketamine-assisted therapy, metabolic psychiatry, and functional medicine approaches to mental health. Her practice emphasizes whole person care, focusing on identifying and treating the underlying causes of mental health conditions, including inflammation, infections, and metabolic dysfunction. Amanda DiMartini, MA LPC, has provided psychotherapy services for diverse clients for 16 years. With a wellness-focused approach, she teaches people to embrace their personalities and moods, to learn to utilize them as strengths, and to recognize when those traits are out of balance. With attention on self-care for nervous system recovery, clients can take on new skills that lead them to reach personal goals. Incorporating ketamine into her psychotherapy practice, Amanda has been excited to see the rapid growth and personal evolution that occurs within individuals who utilize this treatment and witness the improved quality of life that transforms lives of those who participate. She offers a few different ketamine therapy programs ranging from nervous system restoration, chronic pain relief, to trauma support. Thank you, all of you, for being with us today. So I'd love to start for people that are brand new to the topic of ketamine with Michelle. Ketamine's been in the news quite a lot lately. There's a lot of misinformation and information out there. For beginners, I'd love for you to share, what is ketamine? How does it work? And is it a psychedelic, or is it something different?
Okay, so ketamine is a Schedule III FDA-approved drug. It is a dissociative anesthetic, so it is not a classic psychedelic. A classic psychedelic like psilocybin mushrooms or LSD activates the 5-HT2A receptor, which is a serotonin receptor. Ketamine, on the other hand, is a dissociative anesthetic. It's been around for over 50 years, and it is indicated now for treatment-resistant depression, and it acts as a very rapid antidepressant. And the mechanism is really that it works on glutamate, which is one of our excitatory neurotransmitters. So when we used to think that depression was a deficiency of serotonin, and we would be taking medications that like SSRIs or SNRIs. Now we're more aware that things like chronic stress can actually create changes in the brain, like the prefrontal cortex, where we have atrophy of certain neurons that allow us to not behave the same way that we used to. For example, someone may not be motivated or not really able to change the loop that they're thinking. So ketamine blocks the NMDA receptor, and that receptor is responsible for neuroplasticity. It increases glutamate very quickly, and that glutamate surge creates a very quick window for people to feel better, to find some motivation to change and create plasticity. It also increases BDNF, brain-derived neurotrophic factor, which a lot of the other classic psychedelics activate, as well as things like exercise. So that also creates this change or adaptation in the nervous system. And we use it for things like chronic pain, PTSD, depression, because these are all states where the default mode network becomes hyperactive or hyperconnected. So, for example, people who have chronic pain are often in a mindset that the pain has now become their identity, or they're limited with their function because they can't separate themselves from their condition. And so when the default mode, which is a part of the brain that is, prefrontal cortex is part of that, it actually becomes connected to them in a way that they can't separate themselves from their condition. So it also helps to decrease the activity in the default mode and increase functional connectivity. So other aspects of the brain start to communicate, so the person can really have a different perspective on something. And so being that it's a dissociative, it allows you to really, it's almost like a window to another, your subconscious, let's say. So it actually allows you a little space to reprocess different things, to look at your life in a way that you can really step back and understand how you're in this process, as opposed to participating in it, but more it's taking you. And so I feel like the dissociation sometimes scares people, but at the same time, it offers a lot of benefit in the sense that if you provide a safe container for someone to let go into that experience, dissociation can give someone a different way of viewing the world, a different opportunity. And it's an anesthetic, so people get some pain relief, or they're not really connected to the physical pain in their body. So it's a very, ketamine is really a beautiful drug because it can do so many things. It's also very safe. It doesn't really can mildly elevate blood pressure, but it's a very safe medication. And it has many different uses because of dissociation.
Thank you for that explanation. That's so helpful. And now I'm understanding with your answer, I'm understanding why, even though it's not a psychedelic, I see why it gets lumped in with psychedelics because of its ability to reset the mind. Yeah, beautiful. Thank you. Erica, I'd love to shift over to you with our next question. I've really come to see, we've been working with our microdosing programs for 4 years now, and I've really seen patterns of what mushrooms are really, really, really good at. And some other conditions people present where it's sometimes yes, sometimes no. So I'd love to hear from you in your practice what you've seen ketamine particularly good at, and are there some conditions where ketamine is not necessarily effective?
Yeah, thank you for the question. And I'm going to piggyback off of what Michelle was saying as well. So the evidence really shines for ketamine's use as a powerful antidepressant, particularly for those who have what we consider treatment-resistant depression. So maybe they've tried several antidepressant medications, which is our standard treatment in psychiatry, and they haven't found benefit with them. And then ketamine comes along, and like Michelle had mentioned, it works quickly. And for a lot of people who have been feeling terrible for a long time, there's something really potent in ketamine's ability to help people feel better sooner than our typical antidepressants. The other places that we see ketamine helpful for, there's more and more evidence showing that it's helpful for symptoms of PTSD in people who are struggling with PTSD. And I would say that what I see clinically is that ketamine is a tool to help people understand themselves better. and their own patterns from this place of curiosity and compassion. So what happens with people with all sorts of DSM-5 mental health conditions is the underlying common denominator, and this is getting into the default mode network. The underlying common denominator is that there is these stuck negative thoughts or ruminations. So we think about conditions like OCD, addiction, eating disorders, depression, anxiety, PTSD, and they all have this people have this underlying issue of recurrent thoughts. And so ketamine seems to be very helpful in stopping those thoughts or allowing people the space or some compassion where they're able to not go down that same track that they're stuck in, that loop that they're stuck in. And then from this wider lens of personal growth and self-inquiry, ketamine can be such a helpful tool for helping people who experience chronic lifelong health conditions. So we think of chronic pain. We think of people who are at the end of their life and in hospice. And then from this wider lens outside of mental health, it's helpful for chronic pain, often at higher doses, correct me if I'm wrong, Michelle, than what we use in mental health. And I also think about ketamine and seeing its helpfulness for people with more complex chronic medical issues from a functional medicine perspective, where ketamine, it can help people learn or relearn how to be safe in their nervous systems. And for those who have complex health conditions like mycotoxin or mold illness or mast cell activation syndrome or chronic Lyme disease, what can be really helpful is basically this reboot of their nervous system and immune system. And so ketamine kind of has a role in different places and for people going through different issues and having different symptoms. But what I have found in working with people in ketamine is it does seem to be most helpful for people who can recognize that this is a tool that they can use. It's not a quick fix. It's something where there is continued inner work that needs to be done in the days and weeks and months after the ketamine sessions. And it's also seems to be most helpful for people who are just curious about expanding their perspective and have that curiosity at baseline. For people who it wouldn't be helpful for, I believe at this point, we wouldn't recommend it for people with psychosis or mania, bipolar 1 disorder with mania.
Great. Thank you. I'm so excited. We'll get into this further in the conversation. Each of you has such different approaches and expertise in the clients you work with. So that ties into my next question for Amanda, which is the different applications and way. I've heard there's ketamine lozenges, and I know there's take it at home, there's infusion therapy. So can you talk a little bit about the different types of ketamine therapy and why one might choose one over the other?
Yes, thank you. Well, we've learned over time, we started first with the PTSD, focusing on, PTSD. That seemed to be who was drawn to the program, PTSD and treatment-resistant depression. And so we were doing the nasal spray program for them, where they would be pretty deep sessions. And it does have a psychedelic quality once you do, you layer it with the nasal spray. Many times people will have, a visual quality and sensations. There is usually insight, like profound insight as to, maybe how to re-strategize or problem solve, which is amazing as a therapist to see this when all I've had before was talk therapy as a tool, to see how ketamine is kind of helping with the heavy lifting of some of the evolution that the person is going through. And then that in that, therapeutic container while, kind of paying attention to behaviors, boosting wellness, behaviors as you go, setting in new habits is super important. It's not the medicine by itself for sure. And then, we started doing lozenges with the chronic pain protocol, chronic pain / chronic illness. We're finding people, in both categories, finding a lot of relief and ability to coexist with the condition a little more gracefully. And to kind of carve out some life again out of, feeling kind of stuck and overcome by something. So that's one thing the doctor does, a chronic pain protocol, which is daily. And then also with the lozenges, we're working with a nervous system restoration program now, which is what we learned with over time is some people are right in the middle of stress. They don't have like a vacuum where they're like, oh, I'm post-stress. Now I can really deal with it. I was actually getting a lot of retired people with that program because they can deal with that now. But so when we were kind of operating with, middle-aged people, we were noticing, oh, wow, they're still, in the middle of these stresses. How can we best support them without the destabilizing or like over a little bit of too much attention on the problems. So that's when we started kind of doing, smaller doses. And first we do guided so they know how to use their medicine, and they can do that every third day, or some people just do once a week.
Beautiful. Thank you. I know my next question is for Michelle. I know all of you share moving medicine from this compartmentalized approach to a more holistic, whole person approach. And I know, Michelle, you're passionate about, for example, the link between chronic pain and depression that are not always made in modern medicine, and biopsychosocial care and how that informs how you care for the whole person. So can you talk a little bit more about this approach and any examples of this that you've seen in your practice?
Yeah, so first I would define pain as an unpleasant sensory and emotional experience, because there is no need to have tissue damage in the body in order to have pain. And so when people understand that that's actually the diagnosis, like that's actually the definition of pain, then when you think about depression or pain, is that emotional pain or is it a physical pain? Or, so we're separating, but the person is feeling some type of sensation in their body that they attribute to something that's harming them. And it's important for people to understand that pain can exist without having damage in the body, so that they understand that they can actually become their own healer. Because when you think that the problem's in the body, then you're more likely to ask for someone else outside of you to fix it. And so I think what's happened with a lot of people, and we have not just an opioid epidemic, but we have a chronic pain epidemic where there's 1 in 5 people in the United States have chronic pain. And so it's actually the chronification of pain and depression that leads to these ingrained neural networks that creates these habits and patterns that keep someone stuck. And so when I really assess someone, I do a biopsychosocial assessment. And if you really break that down, bio basically means looking at the person's genetics, how they metabolize certain medications, their neuroendocrine and immune system, peripheral and central sensitization, so how sensitive they are to different signals in their body and also from their brain and to their body. So it's a two-way street, as well as their nutrition and their exercise. Then when we talk about psycho, we're talking about their coping skills, how they regulate their emotions. Different lifestyle choices also would be involved in that. Social would be socioeconomic status, their job, their family situation, their relationships. So when you're treating someone who has chronic pain, there's a component of pain that also involves suffering. And suffering actually has a lot to do with the psychosocial aspects because it will impair function. And so when you ask someone, do they have pain, that's very subjective. And I like to really focus much more on function. So, what are they not able to do that they would like to do? Or what would bring them some type of meaning in their life that they're not able to be connected to. So when we're talking about pain, it's important really to look at the whole person and really to understand the story of who they were before they had pain and what led to that. And so really, I think that medicine has shifted us to try to see patients as fast as we possibly can, which then sets us up for giving them a medication, changing their dose, doing an injection, when really we need to actually take a step back and understand the entire story behind how the person started to have pain and then how they got stuck in this default mode that is so attached to their construct of themselves. And so sometimes taking a better history and spending more time with the person even allows them to actually say it out loud where they understand. They'll say, like, the only thing that decreases my pain is my anti-anxiety medication. So obviously calming the nervous system helps that person feel more calm in the body, and therefore they have less signals that they're interpreting as danger. And so a lot of the patients that I see, we say it's like a broken fire alarm. Like there's an alarm going off in the body, their brain is on high alert all the time, but there's actually no damage in the physical body. And most of these patients have something called central sensitization, where their nervous system becomes hypersensitive. And so they end up having multiple symptoms. It's not just, it's like what you were just saying, it's really chronic illness. It's not really chronic pain. It's not a mystery how people end up having IBS and chronic migraines and pelvic pain and TMJ, and then they go to multiple different specialists and get all different medicines and all different procedures. And really, I say it's like the nervous system is one forest, and these are all the trees that are coming out of it. But what's happening is each individual specialist is treating each individual tree as opposed to treating the whole person. And so, and actually there's almost like a PTSD going on with patients who don't want to go to the physician because they're not being heard and they're not being seen. And so they think someone's going to tell them it's all in your head, and really it may be in the brain. Their pain actually may be in the brain, and we may need to disrupt certain patterns for their brain to reset. But it also involves a relationship between the patient and the physician where they do feel safe enough so they can actually talk to you about some of their deeper thoughts, or really help challenge some of their beliefs that they may not really believe in, but it's kind of ingrained in who they are. And so a lot of what I do is behavioral activation. I like to change their activity and really focus more on their behavior and hope that the thoughts and emotions change, because most of the people I see have already gone through therapy and coaching and they're frustrated at this point. And what we're really trying to do is reset the nervous system by giving them a space to help reprocess what they feel is going on. And so chronic pain, it's really its own specialty. And I think a lot of it started because pain became the fifth vital sign and we had to treat it. So now you have to score it between 1 and 10, and that's extremely subjective. And what we're looking for more now is objective findings showing that there's some type of improvement, which is why I do focus more on function than subjective scales like, depression and pain.
Thank you so much. So beautifully expressed. What you were sharing, I was thinking of so many intake calls I've done where I start the call with the person and they express usually a physical symptom. And as the call progresses, the emotions come out and experiences come out. And I often say, well, when did the pain start? And it's exactly when that experience happened. And that's the first time that they've connected the dots that, oh, my headache started the same time I lost my daughter. Right. And just because we're so compartmentalized, as you just shared, we don't always see that until we're kind of looked at in our totality. So thank you so much. Erica, hot topic question for you. So We're reading a lot about mail order ketamine companies, and lots of people have very passionate opinions about this. However, you practice in a very, very rural area, right? Where a lot of people don't have the convenience to have, a ketamine provider in their area. And they really, to get the access to the healing, they need to rely on distance healing. So I would love for you to get your thoughts and opinions on that, and some safeguards that you might like to see in that arena.
Absolutely. Access is something I think about it a lot. Like Michelle, I think we both have masters in public health. And so kind of this big picture access goes into just thinking deeply about psychedelics and ketamine. And I think it's complex, but it's also a very real issue. And it's one I don't have all the answers to. I wish I did, but I don't. And I think there's different ways that we can approach access while keeping safety and integrity at the front and center of our clinical decisions and what we recommend to people. And just in another vein, another way that we can look at increasing accessibility for ketamine and ketamine-assisted therapy is through groups. And so groups, like in my rural area, I have group ketamine options where people come with anxiety or depression or PTSD. I think people can specialize a little bit more in patient populations with like first responders or new moms or things like that, or people like that. But group ketamine assisted therapy, it's great because people get to have their own individual experiences, but in the whole of being in community with others. So like in my practice, everyone has their own twin size air mattress, their own blankets, and they have an eye mask, and they're all in the same room together listening to the same playlist. And then during the preparation, right after the journey, and then in the integration, people get to share and have that shared experience as well. So I think there are, just thinking more broadly of access, that is a great option. As for ketamine by mail, I think it's considered controversial. I would consider it controversial, but it's important that we discuss it as an option. So on one hand, it can significantly increase access, particularly for people who live further away from clinics, particularly for those who might not be able to afford in-clinic ketamine. But on the other hand, we need to approach it with caution. And this is where the concept of thinking two thoughts at once comes in. So we can recognize the potential benefit of ketamine by mail, while also acknowledging the potential risks involved. And so in my experience, it seems to be best when patients already have an established relationship with either a therapist or a psychiatrist, and then have ideally already initially experienced ketamine in a clinical setting first, so they can understand how the process goes, what it feels like, and how to integrate the effects safely. I would be cautious about recommending mail order ketamine as a standalone option. I know in my practice, it's not an all or nothing. I have certainly recommended it for folks who have worked with me for in-person ketamine, and I know them, and we can discuss the risks and benefits together, and then they can make an informed decision. Because I think the biggest thing is that we need to be, as healthcare professionals, we need to be a resource for our patients, and be, like Michelle mentioned, be a safe space for people to bring these questions and not feel judged or shamed for bringing them up. And we can have like real honest conversations about them. So I think it really just comes down to holding space for both the hope of expanding access and also the necessity of maintaining high standards of care.
Lovely. Thank you. Amanda, one of the things I see and speak to people frequently about when they mention they have tried ketamine is it's very, very common for them to say it worked for a time and then it faded. And I asked them, was there any integration? Were you doing anything? And they said, no, I got the infusion, but then I really noticed a difference, but then it faded. So I would love for you to speak to that. And when people feel drawn to ketamine, what are some of the best practices you recommend to kind of create a container of healing around the ketamine itself to really enhance and extend the benefits of it?
Thank you. I think that's a great question, especially with, we were seeing a lot of infusion clinics at first. Yes, I feel like it's the synergy between the medicine and the skilled, from my angle, it would be psychotherapeutic support, skilled coaching, however you want to frame it. It's really important to create this space and to create this, knowledge of like the neuroplasticity, the benefits that are going to last a while. It's not just while the medicine is in your system that you get the benefits. So when you kind of frame it and their mind is set towards, oh yeah, now I get to really make a change in my life. Now I get to improve these areas that I've been struggling in. You empower them to, this is a first step. This is going to provide some relief. And what I see is a hope. When hope is improved, dialed up, usually the first session, sometimes the second, because sometimes people are a little nervous on the first one and they struggle a little bit. But typically hope is ramped up like huge percentages. And once hope is, it's so exciting because then you get to start seeing, people take action. It's the action part that sustains the improvements. And I think, with the infusion clinics, they're focused more on the medical model, which is fine. But I'm loving what I'm hearing about the other professionals here today using, biopsychosocial. We're doing holistic. You guys are really working on just, the core of the problem rather than, oh, here's a few symptoms, So I do feel like, and then I have seen some people report, about a 3-day kind of relief situation. And I have seen up to like 2-ish weeks of really, notable, smoothing out of the nervous system, not as reactive, symptoms diminishing. But that's kind of why we, started leaning into, hey, what if we make this, an every 3rd day or a once a week option at a lower dose? Can we still get all of those benefits, longer term? And, with physician and therapist eyes on it, we can help, get that, see the potential and kind of guide it. And we are kind of creating a system where we can do this statewide and the pharmacy can deliver the medicine. But with our system, they are trained, guided on how to use the medicine. And I do feel like remote is fantastic in a place like Missouri because, people can be hours away. So we are developing it so we can remotely guide as well and then do follow-ups to support until they're comfortable utilizing the medicine.
Love it. Thank you. And one of the things I love about you three so much is how the innovative ways you're modeling these things. Like what Erica described, it immediately reminded me of like the community acupuncture concept where people can come together and share in the experience and have the power of the group while they're experiencing the practice itself. It just amplifies the effects of everything. Or supported remote work that's codified and safe is beautiful. So thank you so much. Michelle, I'd love to dive deeply into one of your passions and chronic pain, because as you said, like so many people report that among their intentions and hopes on their applications is working with their pain. So I know this is a huge specific focus of your practice, and you also bring other plant medicines in sometimes to the treatment of such. So can you share a little bit more about people who are listening, who are experiencing chronic pain, how you would approach working with ketamine and perhaps other plant medicines for that?
Sure. So when I was trained in 2012, when I was trained first with ketamine, we used to do IV infusions Monday through Friday for 4 hours at a time, really not paying any attention to preparation and integration. We were just treating chronic pain. Most of them had something called complex regional pain syndrome, which is a hypersympathetic nervous system state where they have pain after a fracture in a limb or something like that. Or, a lot of neuropathic pain, that numbness, tingling, burning type of sensation. And so this was 12 years ago. And the idea was that if we were to quiet their nervous system for a certain amount of time, that it would help reset it. And that's how we would create neuroplasticity. When I understood the advantage of dissociation, meaning the fact that we can actually not just use ketamine as an anesthetic, but put them into this dreamlike state at a sub-anesthetic dose where they're able to have access to other parts of themselves that they never had access to, I realized how the pain doctors were not really taking advantage of what the psychiatrists knew. And it was really interesting for me because then, a lot of people would ask me, do you treat pain the same way as you treat depression or PTSD? And my answer is I'm treating the person. I'm not treating the condition. And so a lot of times someone who has, let's say, chronic pain, or let's say they have fibromyalgia, they also have depression. If they went to see a psychiatrist for depression or PTSD and they had fibromyalgia, would their fibromyalgia improve from the ketamine that was given by the psychiatrist? Or just because they have chronic pain, do I need to give them higher doses and IV infusions and not prep them and, not integrate them? So I just really took a step back from the literature because the evidence is very far, is really not there yet. Like what is actually being published now is not what we're actually doing. It's like we're building the car as we're driving it, and that doesn't sound great. But at the same time, that's what's happening because we're learning more and more. And I'm realizing that in order to treat the person, I have to look at how anxious they are, for example, how willing they are to surrender to the medicine, what their situation is like at home, who they're going home to, how safe they feel talking to those people in their life, how willing they are to understand that pain isn't just in their physical body and that they actually have to participate in order to get better. So I make all of the people who have pain participate with my coaches. We do preparation because there's still a story there and they're too attached to that story that they don't want to let that go in order to change. And really all pain can change. And a lot of times they're resisting that change because they think that change would be more painful. And really, we have to get them to a place to feel safe enough to then see the other side of that. And so when I treat someone with pain or depression or PTSD, I'm just treating the person. So, I could see someone like I saw someone today who has chronic pain, but it's really central sensitization. There's migraines, there's numbness in different parts of the body, TMJ, and there's no real cause, and all the imaging and blood work, you can tell by the story. And that person also has a very anxious experience, like that when I experience them, that they feel a little bit anxious to me. So that person may be better off, let's say, with an IV or a very low dose of an intramuscular. But it's really based on the relationship I'm developing with that person, how willing they are to let go. So a lot of times, I know it's not a great answer. Like, people want to know what with someone who has pain, this is how we do it. This is a protocol. I mean, for the most part, I could say the protocols are usually, this weight-based dose of 0.5 milligrams per kilogram that over time, whether it's twice a week for 6 sessions or once a week for 6 sessions, usually in a short period of time, we like to give a few sessions of ketamine. That's just creating neuroplasticity. The half-life of the drug is very short, and they have that critical neuroplastic window for up to 72 hours after. So you want to do the integration then, have them become very aware of their habits and their lifestyle choices. But in general, when I treat a person, I'm just treating that person. So I generally prefer intramuscular. I usually do 2 shots that are divided by 15 minutes. Usually the first dose is lower, And then as they feel comfortable, we kind of do a little breath work and meditation, get them adjusted to that space. Then we give them a second dose, which is usually the same or a little bit higher, that sets them on their journey. Obviously, they're listening to music, they have eye shades on, they're in a recliner or lying in a bed. And so I prefer intramuscular. I feel like it's more relational. I can interact with them and I can understand how they're feeling first and before and after that second shot, because usually they say everything was calm and then I went into that second shot and then it kind of picked up a little bit. Sometimes I do more IV infusions if the person seems more anxious, or I don't feel like we'll be a good historian, meaning if I come in and I say, how you feeling? Or you're ready for the second shot? I don't want them to have to think I'm coming in and they have to answer me. And is this the right answer? Because there is no right answer. So sometimes those patients, I'll do more of an IV infusion so that they can just kind of rest and really let go into the experience and let it unfold. And then for some of the pain patients, I'll do longer infusions if they can tolerate that. I don't think there's any evidence to say that a longer infusion will create more pain relief or longer lasting pain relief, but sometimes they have more time in that space to help them reprocess different things. So I think that treating the patient is the most important, but I would like to see more evidence looking at chronic pain using intramuscular dosing with preparation and integration. I think that a lot of people are in this fear pain loop where fear exacerbates their pain. And so a lot of times they feel a sensation in the body and that has a little bit of an anxiety quality. And then they attribute that sensation to pain, and then it becomes amplified. And to what you were saying before, hope is a big part of that. If they feel that there's no way for them to get out of this loop and they're kind of stuck in this body, then they don't really have any hope. And I feel sometimes just, awe or the mystical experience gives them hope because it shuts their ordinary mind down and also just gives their body some pain relief, just a whole break in that pain cycle. So I think it's like we say, it's catching fears. Like I want them to catch their fears as they're happening. I have them track in their body how they're feeling to see if stress or different things can exacerbate that. We obviously focus on a lot of lifestyle choices. Sleep is a big one for pain and depression, making sure that they're getting good sleep, making sure they're moving their body, they're interacting with good people. And also after their ketamine session, doing things that are new or things that they enjoy or things that are not very stressful is also really important. So we like to put together a whole protocol, and we call it a pacing protocol, where we give them certain things to do and we increase that over time. Maybe it's exercise or certain habits that they want to look at or certain beliefs that they have. But ultimately, we're trying to create more flexibility in the body and the mind. A lot of people have this rigidity, which keeps them stuck. It keeps their muscles tight. It keeps their fascia really tight as well. And sometimes just, it's like, do we relax the mind or the body first? But usually if you do one, the other one hopefully will follow.
So beautifully said. Thank you. Erica, I have so appreciated in you and following you and your work, your thought leadership and kind of pushing the field of psychiatry forward and evolving it. So I would love for you to speak to, in the field, what you see as kind of the biggest obstacles and challenges within the field right now, and also kind of your hopes and the bright spots that you're seeing right now.
Happy to answer this question. And I feel like it's an evolving answer. I think back to when I first got introduced to ketamine assisted therapy through the Ketamine Training Center several years ago now. And I really didn't know what to expect. All I know, I was in upstate New York with 40 allied healthcare professionals. And I went in with this curiosity of like, I don't know if this could be a helpful modality for my patients, but like, gosh, we're limited as to like what we have in conventional psychiatry. And at that point, I was already in my private practice. So I think I already had a little bit more, or felt like I had a little bit more freedom and autonomy. to shift my practice based on what I felt like or what was helpful for people. I think that is like overall from a systems issue, it's much harder to do in a larger system to be able to even like think and have that curiosity. And once I completed the training and did the experiential aspect of it, it has really affected how I practice psychiatry and in ways that I could never like predict. And I think that some of the biggest takeaways that came from it is really allowing myself not to be the expert when I meet with people. And I think so much of ketamine and probably psychedelic medicine, it's really, and this is what I share with patients, this is your experience, and I'm not here to tell you what to do or what to experience or what something might mean. The goal of this is for you to have your experience. I'm here to kind of provide some physical safety in a container, but what the important part is for you to go within, be curious about what you find there, and then we can explore that together of what comes up. And so it kind of takes away, because in psychiatry, I think there's much more of this history of like, there's this patriarchal feel to psychiatry where we are the ones who know all the answers and we're here to give you a medication that will fix this problem. And so what I found with ketamine is that it really has opened up the way that I practice, and not saying that I was down that path, but I had to unlearn a lot of what I learned in my training. And ketamine assisted therapy and practicing has really helped me on that journey. And so I think there is this like curiosity and letting go of ego that comes with practicing in this way and offering ketamine as a psychiatrist. And I would say one of the biggest challenges beyond the like logistical issues with insurance reimbursement and the way that our healthcare system in America is that there is this reluctance or even sometimes a resistance to be curious about treatments beyond what we traditionally offer, which is talk therapy and psychiatric medications. We're getting more into like TMS, for example, but overall, those are kind of the two options that we've had. And so I've personally done a lot of reading about the history of medicine and the history of psychiatry, just so I could like understand where we were coming from, because there is a lot of missteps that our field has taken. And I can empathize and understand why my colleagues might be hesitant to consider these approaches that aren't what we typically have done. But I feel like that can also hold us back from these more innovative approaches that are now showing more and more evidence behind them. And it's been fun because I've seen my psychiatry colleagues kind of watch my path through into ketamine assisted therapy in my private practice kind of from the sidelines. And I think there was a lot of initial hesitation with ketamine assisted therapy. But what's been interesting is that they have patients in their clinics who go elsewhere for ketamine treatment, and they come back to them and they share their improvements and the benefits that they've had. And that's like what forces our field to really pay attention. So with that, I'm really hopeful. And even in the past 4 years, I've seen this shifts in attitudes. I'm hopeful that more healthcare professionals, not just psychiatrists, but allied colleagues as well, will become open to integrating ketamine into their practices and or other holistic therapies. Patients, they just want alternatives. They're seeking alternatives to daily medications due to either side effects or just plain a preference of not wanting to go the route of taking a medication every day. And I think it's our duty and our responsibility to help meet that need. People don't always want to be suppressing their emotions, which are what our antidepressants tend to do. And so a lot of times people want to learn how to feel their feelings safely. And ketamine can be a really helpful tool to help people do that. And I think there is like this bigger uncertainty of psychedelic medicine in light of the decisions of the FDA with MDMA. There's kind of this uncertainty of the future of psychedelic medicine at large. And at the same time, we can be grounded and focus on what's available, what's legal, what do we have now, what tools do we have now, like ketamine, and then we tailor it to each patient's preferences, their symptoms, their life story. So that's whether they want more of this procedural IV approach or they want more of a spiritual approach. I think it's just so important that we know our patients and we have that flexibility to meet them where they're at. And so I think ketamine can be a really helpful tool for allowing us to do that. And I guess my hope is that more psychiatrists in general, in specific, are willing to step outside this box to embrace this more whole person healing. And not only can it help our patients, but honestly, it's just a really incredibly rewarding path as a physician, I would say.
Beautiful. Thank you. All of it. So much. Amanda, I have noticed, especially in the last 2 years, so many people who are coming to our microdosing community from the Midwest, from the South, they express they're interested and drawn to microdose, but they're equally interested with being with like-minded people and having other people they can talk to that aren't judgmental, that don't have a lot of fear and stigma around it. And so I would love to hear from you, some best practices or advice, your experience with clients who are coming that are drawn to these healing modalities, but they have family members and they're in a community where there's a lot of stigma and a lot of judgment. How do you hold that and how do you approach that healing with your patients?
Well, that's a good question. And, people have been very guarded about their personal practices. Even I deal mostly with anxious people, even regarding cannabis. So, cannabis here like 6 years ago went to medical, then we went to recreational, I think 2 years ago. So it's really been interesting because watching the evolution of people, really treading lightly and, because they think they're going to get, some authorities called on them if they were to ever mention, a practice like that. So it has been interesting, like softening up the dialogue and opening up space for, yes, there's medical use for this. Let's talk about that and how you can use it wisely. So even that, has been different with people and watching them communicate, differently and having that caution. And then when we open it up, they're able to, sigh, a little bit and move forward. And yeah, the same thing, with this is, talking about the science of it, I think, and like kind of just having a few outlets for, some summaries of research, the brain stuff, that the neuroplasticity, the inhibiting the excitatory neurotransmitter, these types of things seem to break through a little bit and warm people up to the potential. But usually the people who are drawn to me usually have been doing the research already and they're pretty sold on it by the time they even call me. So it is interesting that people are taking a little bit more curiosity and like self motivation to consider things outside of the traditional approaches that aren't as fulfilling or rewarding or delivering the results they're looking for. So yeah, curiosity, showing them a little science and letting them know it's a safe space and that we're talking about medical use of things. I think that helps people bridge that and not feel like they're a criminal.
Mm-hmm. Absolutely. Yeah. I always tell people too, they're always surprised to see how many other people there are that are like them. I can always see like when people come out to their first call and they see all the others, they're like, oh my gosh, there are so many more people. And I think same thing with our spirituality. A lot of people feel like they need to hide that because they're in a certain role or a certain profession. But then when they start to open up their spiritual side and talk about these experiences, people are just breathe a sigh of relief that this is safe here. I can share this here. So thank you so much. Michelle. So right now, a lot of people are hearing about ketamine for the first time, unfortunately, due to the Matthew Perry case. So a Hollywood actor, well known, passed away. Ketamine was involved. And I know a lot of opinion states that, medicines are safest in the hands of prescribers. But this was definitely a case where the prescribers were in charge and unfortunately were not practicing ethically. So I would love to hear, given the nature that ketamine is addictive in some cases, what are your thoughts around this from how you've seen the field evolving over the last few years? You've been at this for quite some time and had a window that not everyone has had. So I would really value your opinion on this and how you've seen it evolve, where you kind of see it going off the rails, and how you can see ketamine being held differently than, say, opiates.
I think in the case of Matthew Perry, we see that profit was more important than safety. And when physicians are prioritizing financial gains over their patients' health and wellness, then clearly there's going to be some type of consequence. And so I think this is a great example of where we need checks and balances in the medical world. For example, in Florida, we have something called eForce. eForce is a way that physicians can check any controlled substance prescribed to a patient. So if I'm going to give anyone any type of controlled substance, I would look before and see if they're on other medications to see if there's interactions or to see if they're getting that same medication from another provider. And with ketamine, I believe you can find it on our eForce, or in other states, they have other programs. So the problem there is why the physicians were not checking and seeing that he was getting that medication prescribed from potentially a compound pharmacy, or really they were just really prioritizing profit. And I think that he was taken advantage of because of financial gains. And that's one aspect of it. And the other is the checks and balances that should have taken place. But, to go a little bit deeper, I would say the container that he was in was a hot tub. When we talk about safe containers and holding space, right? Like there's no need for anyone to be outside of their doctor's office or with someone that is really caring for them when they're going into dissociation or a psychedelic experience. The fact that he was in a hot tub probably created a horrible container for him to drown. But yes, it could have been from taking large amounts of ketamine and having this dissociation where he feels that he was somewhere else, for example. But also there's nobody else there to safeguard him, what's going on. So I think the actual container is really important. I know that for me as a pain doctor, I've even changed my physical office to look more like a therapist in a psychiatrist's office, where they would feel more comfortable coming in. That setting is really important for just that, change in their nervous system, because they're already coming in a little bit anxious. So in his situation, obviously a hot tub is not the right container to do any psychedelic or dissociative. And I also think there's probably no intention setting. There's probably no integration with the work he was doing. And Gabor Mate said, don't ask why the addiction, ask why the pain. And I think that a lot of times we need to go a little bit deeper and not judge someone for having the addiction, or just really understand where this came from and help them cope in a different way. And so I think that ketamine is interesting because it can treat addiction and it also can cause addiction. And I do find that more and more people who are using ketamine that potentially are not doing it in the office are more prone to having this addiction because they find an easy way to escape. And really, ketamine is a form of, escaping. You're actually trying to leave the story that is harming you or leave the physical pain that is causing you distress. And at the same time, that dissociation can become addictive. They can be trying to leave and dissociate because they don't want to deal with the pain anymore. People who have PTSD or physical pain, they dissociate as a normal coping mechanism to dealing with their pain. So I do think in the wrong hands, without guidance, there can be an addiction to ketamine. And I still think that a person who has the ability to have an addiction, it can be to any substance. So if you're exposing someone to ketamine, that can create more of a potential for them to desire the escape, let's say. So I think it's really important to do the assessment and understand who we're treating. But I also use ketamine to treat addiction. I have many patients who are overusing alcohol, opioid use, I would say eating disorders as well, OCD, things like that. I do find it to be very effective, but that's with preparation and integration, paying attention to the dose, doing it in the office. So all of these things were not done. And unfortunately, it's created such a stigma to talk about ketamine in such a negative way, to the point where I have a new patient coming to me for ketamine that then questions whether they want to do ketamine because of Matthew Perry, which to me really makes no sense. You're coming to the office, we're paying attention to all the details that we should, but they're assuming that this drug could kill them. And it's really, a very safe medication. That's what we keep forgetting. And actually, ketamine could be very gentle. You could give someone a very low dose and they just feel like they're having, a dream or like a deep meditation. I think education is the most important, that it really has to do with the container and the dose and the patient and physician's relationship, where we know that we're on the same page towards that person's health as opposed to profit, unfortunately.
Thank you so much. Yeah. I mean, we saw that too with the story of the pilot taking mushrooms and crashing the plane or threatening to crash the plane. And same thing. It's again, it's not the substance, it's the human. Right? That's an issue. So yeah, thank you so much. Erica, so I am part of a mastermind group of medicine guides focusing on microdosing work. And it's so much fun and it's so fascinating learning together and having people have such unique approaches to what is a very similar field, right? And so I know you're passionate about working with other psychiatrists that are bringing ketamine into their practice, encouraging them, inviting them. So I'd love for you to share more about that, like the power of interdisciplinary use and kind of learning and growing as a field together.
Yeah, I think there's something really powerful about the interdisciplinary nature of ketamine, and not just in terms of medicine, but more so that it connects psychiatry, psychotherapy, psychology, hospice, palliative care, pain medicine, plant medicine, law, ethics. So it's this melting pot of people with different perspectives and different lenses. And I think there's something so rich and beautiful about that. And then even religion and spirituality, I guess I would include in that too. I have a friend here in town who's a Lutheran pastor, and we get into conversations about psychedelics and just like the interface with medicine and religion. And in many ways, this aligns with philosopher and author Ken Wilber. So he has this concept of holarchy. So it's more so where systems build upon each other in an integrated way rather than a reductive manner. And so with this philosophy, it's really about creating a whole that honors each part's contribution without diminishing it, which is exactly how I see ketamine working in conjunction with even conventional medicine. I think in medicine, there does seem to be like kind of this hierarchy and a diminishing or reductiveness to it. And so thinking more along the lines of holarchy, where we're not detracting from traditional understanding and healing and treatment, but we're expanding on them and adding in these layers of understanding and healing that conventional medicine alone may not offer. And so through ketamine therapy and ketamine, we're helping to challenge and reshape, I would say, how we see hierarchy in healthcare. And so instead of thinking in these terms of either or, it's along the lines of both and. So how can we integrate these therapies and allow patients to benefit from this more of this broader spectrum of care. And so I think this is really like what we need to adapt and embody, not in psychiatry, but in medicine, the whole world overall.
Beautiful. Thank you. Amanda, I love to close each of my episodes by asking and inviting guests to share, set aside all restrictions, realities, regulations, and share kind of in your dream and vision how you could see ketamine in particular in this case being incorporated across our culture and society in a way that's safe and accessible and equitable.
Thank you. Well, I mean, thus far, I'm appreciating the coaching, guiding. I love that both of these ladies are doing that too. I think that's so cool because I have a team. So I do the therapy coaching part, the psychosocial stuff. And then physician handles his holistic, wellness from the biology and all his magic. But I do feel like a combination of both is necessary. I don't feel like this is one you can be like, hey, take a few, call me next month or whatever. This needs to be guided. You need to teach people mindfulness, intention, integration, how to use a medicine wisely so we don't end up with like a repeat of an opioid type of situation. We have to have such respect for the medicine and understand medicine can also be a poison, how we're using it, our intention, and dosage is very important and having some eyes on you. So I love that, physicians are going to be kind of looking over that. I do feel like that's important. I do like, the therapist or coach to also have a role until, maybe the person gets a pretty expert use at it and they're using it for chronic pain. We do lozenges for chronic pain, and even that's effective, which is really kind of remarkable that you can do lower dose. But yeah, just having touch points on physical and mental well-being, I do feel like is the most sophisticated way we can use this medicine.
Beautiful. Thank you. Erica, how about you?
In my ideal world, to give a little bit of context, I also work in an inpatient psychiatry unit. And so in my ideal world, ketamine therapy would be fully integrated into our healthcare system, and not just from a procedural, come here for 2 hours, take this nasal spray, but where we provide the support that people benefit from. And so where they could either access ketamine with the supervision of psychiatrist or someone trained in ketamine, and they could get it in the emergency department, they could get it inpatient psychiatry or in outpatient clinics, and where it would be, ideally available and equitable in rural communities and more underserved communities. And then again, emphasizing that it would be administered in safe and supported environments where therapy and mental health are not just like a side thought, but an essential part of the whole process as well. And then also where we get to know people well enough, our patients well enough, where we can guide them as to like the right mode of administration and modality that's best suited for that person. Again, whether it's more of this procedural approach, mystical, or something in between. And ideally, it would be covered by insurance and also readily available in group settings that would make it more financially accessible for more people.
Love it. Thank you. Michelle, how about you?
Yes, so I agree that what's a big issue right now is insurance coverage. And a lot of times I have to try to get the patient authorized for Spravato because that's what insurance covers. And, perhaps that medication can help. And at the same time, that medication also requires the patient to stay on an antidepressant and to take continuously throughout their life. And so, to me, I look at ketamine like a catalyst to create change and help reset the nervous system and disrupt whatever ingrained patterns need to be disrupted to create that flexibility. And so if we're looking at ketamine just as one tool, then what I really want to see covered are the coaching and therapies that would support the ketamine. So like I do something called pain reprocessing therapy. Many people do internal family systems. There's all different types of therapy. If that were to be covered, and then we can just use ketamine as that tool, as opposed to what's happening now, people want the ketamine and are not able to afford the coaching and the therapy. And therefore, we're getting too many people that feel well for a short period of time. Then they think they relapse and they need more ketamine, but perhaps they can't afford it, or they think the ketamine failed. And so I think it's also proper education to understand that that ketamine may require maintenance, but the goal is really to help the person attune to their own nervous system, to understand what that means to them, and to really make them their own healer so that they don't need these medications. So it's really just using it as a tool. But I think the biggest issue is longitudinal evidence showing that it does have long-lasting effects. However, there's so many different protocols and there's so many different ways that people are practicing. So another part that I would like to see is cooperative sharing of information and having physicians really talk about what they're doing with patients, giving more case reports and publishing case series to understand how we're actually using it in practice, as opposed to just talking about the mechanism and route of administration and dosing.
Thank you, all three of you, so much. I know so many people listening are going to be, I want her. I want them as my care team. So can each of you share how to find you? You know, so many of you have such beautiful writing and speaking. So I would love to give people the opportunity to find you on social media if you're on social. So can you share, starting with Michelle, where folks can find and follow you?
Sure. So my practice is in South Florida and in Miami, Boca, and Hollywood. My website is drmichelleweiner.com. Same for Instagram and LinkedIn, just Dr. Michelle Weiner. And I have a lot of things on social media, and you can even email me. And I would love to respond, because I really like education, and I like this is a really great time for us all to just communicate and hear so many different opinions, but we all kind of have the same message.
Thank you so much. Amanda, how about you?
So you can find me under Amanda DiMartini, D.I. Martini. I have Psychology Today. And then also my website is thriveandbewell.com. And that's pretty much where I'm active.
Beautiful. Erica, how about you?
My clinic website is driplessintegrativepsychiatry.com. It's a really long website. And then I'm on LinkedIn. I'm on Instagram at Dr. Erica Berger. And I think that's it. But just to echo off of what Michelle said, this has just been so wonderful to hear each of your perspectives and lenses and wisdom. And just, I feel like I've learned a lot from sitting here and listening. So thank you all.
Likewise. Great. And we'll put all those links in the show notes too. So those of you listening, you'll be able to go back in the transcripts and scoop those up. So yeah, just big hugs and deep gratitude to all three of you for being here, for the beautiful work you're doing, and most importantly, the way you're doing it. You know, it's so, your approach and your perspective is so refreshing, and hopefully just more and more of that in the future is coming forth. So I appreciate all of you. Thank you so much.
Thank you.
Thank you.
Bye, everybody. Thanks for listening. We'll see you back in a couple of weeks. Thank you for listening to today's episode of the Microdosing for Healing podcast. Are you ready to take the next step? Please visit us at microdosingforhealing.com to access our free Microdosing 101 workshop. In it, you'll learn more about our diverse community, our supportive group programs, and discover if earth medicine practice might be right for you. See you in the next episode.